I'm covering the topic recent advances and outcome in BPD. My moderator is Dr. Chinmay sir. The specific learning objectives are the outcome in BPD and the recent advances in prevention, treatment, and diagnosis of BPD. In outcome, the mortality in case of severe BPD is around 10 to 20%, and the risk of mortality is particularly high in infants with BPD associated with the pulmonary hypertension. The most common causes of death in infant with severe BPD are primary respiratory failure, refractory pulmonary hypertension, and acquired infection. And morbidities, around 34% require at least one hospital readmission by 1 year of corrected age. And pulmonary outcomes are recurrent pulmonary infection, particularly during the first 2 years of life, and asthma-like symptoms in less than 32 weeks of gestation, around 40%, and in late preterm infant 32 to 36 weeks, it is around 15 to 20% risk of asthma-like symptoms, that is small airway disease. And abnormal functions, pulmonary function and reduced exercise capacity, and pulmonary hypertension, and acquired airway abnormalities such as tracheobronchomalacia, subglottic stenosis, and some required tracheostomy and chronic ventilatory dependence. The next is cardiovascular complication, systemic hypertension. It is transient finding in the first year of life and lasts approximately 4 months. And 50% of patient with BPD will have received the medical therapy. And the pathogenesis of systemic hypertension is uncertain, but may be caused by increased level of catecholamines, angiotensin, and antidiuretic hormone, or altered regulation of neurohumoral regulation, and glucocorticoid therapy can also be contribute to the hypertension. Then another is left ventricular hypertrophy may be associated with BPD. And next is pulmonary vein stenosis, which is seen in 5 to 10% of infants with severe BPD. Again, the pathogenesis is uncertain, but may be related to the persistent lung inflammation in infants with severe BPD. Then neurodevelopmental outcome, such as cognitive impairment, motor impairment, hearing loss, vision loss, behavioral and mental health problems. Neurodevelopmental outcome, one study was there suggestive of increased BPD severity is associated with increased risk of neurodevelopmental impairment at both 2 and 5 years of corrected age. And the absolute incidence of neurodevelopmental impairment is increased significantly from 2 years to 5 years of corrected age for all BPD severity categories. But this increased risk was similar at both times of point in each category. And growth failure, weight mostly affected, and head circumference is least affected. Delayed growth seen, and weight less than 2 standard deviation in 20% of infants. Head circumference and weight is seen in around 10 to 20%. Then we see the recent advances in diagnosis of BPD. In diagnosis, people studies the lung ultrasound score. The lung ultrasound, this is the one of the prospective cohort study in 59 very low birth weight infants. They have studied the lung ultrasound score in 3 different areas of each lung. They found that there is a lung ultrasound score can predict the diagnosis of BPD at 1 week and second week of life, and may predict the moderate to severe BPD at 4 weeks of life, with in sensitivity of around 70 to 75% in first 1 and 2 week, and specificity around 80 to 100% in first and second week. And in moderate to severe BPD at 4 weeks of life, sensitivity is 100% and specificity is around 80%. Then another similar study done on suggestive of lung ultrasound predict the BPD at 7 and 14 days of life. The ultrasound score scores increased with the increasing severity of BPD, and the score more than 8 was independent factor in the prediction of the BPD. At day 7 of life, sensitivity is around 83% and specificity is 60%. And day 14 of life, sensitivity is around 66% and specificity is 82%. A systematic review on the ultrasound lung ultrasound score for early prediction of BPD suggest similar finding, that is lung ultrasound and extended lung ultrasound shows the good diagnostic accuracy predicting the BPD at day 7 and day 14 of life. Then this is the neonatal research network site showing this neonatal BPD outcome estimator, but this shows the probability of outcome and expressed in percentage, but is not for Asian population also. Then there are some early prediction for early prediction of bronchopulmonary dysplasia. There are newer emerging non-invasive monitoring methods. That is, we can these are the biomarkers in urine, umbilical cord blood, tracheal aspirate, and exhaled breath condensate. These are the inflammatory markers, oxidative stress related markers, and angiogenic growth factors. And the newer term omics has is emerging, which includes the genomics and epigenetics and metabolomic, proteomic, and microbiology. We can see one by one each. These are the some newer biomarkers in the umbilical cord blood for which are associated with BPD. Some are increase in levels in associated with BPD, such as interleukin 6, SGP130 molecule, endostatin, and PIGF molecule, KL6 molecule, and metalloproteinases 9 molecule, which shows the higher level in case of BPD. Then some are the urinary biomarkers associated with BPD. These are all inflammatory oxidative stress related markers and pulmonary and neuroendocrine markers and circulatory stress markers such as anti-pro-BNP. These are higher levels and associated with the risk of increased risk of BPD. And the omic term, which contains genomics and epigenetics, shows the increased level of VEGF and miRNA levels. miRNA RNA levels or decrease, and in proteomics, that is chitinase 3-like protein show in the urine, which was higher, suggesting increased risk of BPD. And it metabolomics, the oxylipins shows the higher level, and metabolites of fatty acid oxidation, androgen and estrogen formations levels are higher. And histidine, glutamic acid, citrulline, glycine, isoleucine, acylcarnitine levels are higher. Lactate, taurine, and myoinositol levels are also seen increased. Alanine and betaine. Then microbiomics suggested the proteobacteria, uriplasma, and strenotrophomonas are higher associated with the increased risk of BPD. Then we see one study showing the N-terminal probe type of neuropeptide, nitriuretic peptide as a predictive biomarker for BPD or death due to bronchopulmonary dysplasia in preterm neonates. It is a systematic review showing a newborn suffering from BPD had a notably elevated level of anti-pro-BNP levels after birth when compared with the healthy neonates. And area under the curve meta-analysis showed that anti-pro-BNP was very accurate in detecting the neonates at risk of developing severe BPD or dying from the disease. This anti-pro-BNP is useful as an early biomarker for BPD in very low birth infants. Anti-pro-BNP at 14 days of life could be used as an early marker of later BPD development in VLBW infants. Then another study, a systematic review showing the low quality evidence suggests that the anti-pro-BNP and BNP have adequate diagnostic accuracy for diagnosing and monitoring of BPD associated and associated pulmonary hypertension, and may be used to triage the patient to receive an echocardiogram. Then we see the study on the proteomics based mapping of BPD associated changes in non-invasive accessible oral secretions. They have collected the samples during the first month of life. Total 607 proteins unique to the oral secretions, 327 proteins unique to the tracheal aspirate, and 687 overlapping proteins belongs to the pathway involved in the immune effector process and neutrophil dysregulation and leukocyte mediated immunity and metabolic process, of which 30 they have identified 37 oral secretion proteins showed the significant differential abundance between this BPD cases and control. 13 were associated with metabolic and immune regulation, and out of which 10 have been linked to the BPD and other prematurely related lung disease based on the blood and tracheal aspiration investigation, but not the oral secretions. Another study on proteomic analysis in preterm umbilical cord blood. Development of BPD is associated with changes in the plasma proteome of preterm infants, and the levels of proteins such as AOC3, that is amino oxidase copper containing 3, and H4C4, that is H4 clustered histone 6 in the blood stream could serve as a biomarker for early detection of BPD in the preterm infants. And Golgi membrane protein and lipopolysaccharide binding protein and X-ray repair cross complementing protein 6, they play may a crucial role in development of therapies for the BPD. Then we see the on the analysis on the variable metabolites in the preterm infant for BPD. The meta-analysis showed the amino acid were identified as a key metabolite distinguishing the preterm infant with and without BPD, of which glutamate potentially serving as a BPD predictor. They found the higher level of glutamate concentration in the BPD group compared to the non-BPD group. Then novel therapies targets uncovered by the genomic-wide integrative analysis in the BPD. They have identified the highlights the importance of integrating GWAS with sequential RNA to uncover the novel therapeutic targets for BPD. They have identified the 4 pairs of markers genes, and these genes are primarily expressed on the myofibroblast, differing from the cell type and genes identified in the previous studies. Then these are the list of genes and associated proteins related to the associated with the BPD, and this study have highlighted the potential role of molecular pathway involved in the inflammation and lung development in the affected infants. And the rare mutation in the ABCC3 and surfactant protein B and C can also result in a severe form of neonatal onset interstitial disease and may also potentially affect the course of BPD. Then another study this showing the association of placental dysfunctional placentation endotype of prematurity with BPD. When the placental vascular dysfunction is accompanied by the fetal growth restriction or being born SGA, it is associated with increased risk of developing BPD and pulmonary hypertension. And is the placental dysfunction endotype of prematurity is strongly associated with the vascular phenotype of BPD. Summary for the diagnosis of recent advance in diagnosis of BPD. Lung ultrasound and extended lung ultrasound showed a good diagnostic accuracy in predicting BPD at 7 and 14 days of life. And we can use this use of several biomarkers in the umbilical cord blood, urine, tracheal aspirate for identifying the preterm at risk of BPD. And the omics sciences have emerged as a promising new approach for BPD forecasting. And the placental dysfunction endotype of prematurity is strongly associated with the vascular phenotype of BPD. Then recent advances in management of BPD. The first we see the prevention of BPD. In that case, this first is stem cell therapy. The stem cell therapy shows the decreasing severity of BPD in the transplanted group compared to the control group. Second is erythropoietin. The erythropoietin has a doubtful role. Meta-analysis shows no difference, and the PNER trial, that is preterm erythropoietin neuroprotection trial, shows no reduction in the incidence of BPD. But when combining erythropoietin with the mesenchymal stem cells, shows the potential in attenuating lung injury by promoting the angiogenesis and decreasing the fibrosis in murine hyperoxia-induced injury model. Then another is recombinant human Clara cell 10 protein, which has also no role in prevention of the BPD. Then superoxide dismutase studies found that there is no correlation between the risk and BPD. Next is inositol. Recent Cochrane view shows there is no role of inositol in BPD prevention. Then another is docosahexaenoic DHA, that is docosahexaenoic acid, which has a doubtful role in prevention of the BPD. Then next is recombinant human insulin-like growth factor complexed with recombinant human insulin-like growth factor binding protein 3. It has a role in prevention of the BPD, but it is under phase 2 trial. Then these are the factors showing promise in result in the preclinical phase. These are hypoxia-inducible factor 1 alpha, vascular endothelial growth factor, anti-inflammatory agents like interleukin 1 receptor antagonist, and non-coding and microRNAs. Then is there any role of SOD? There is a role of superoxide dismutase is doubtful, and also the vitamin E role is also doubtful because of insufficient evidence, and there is no role of cromolyn sodium in the prevention of the BPD. There is a definitive role of this breast milk in prevention of BPD, as already covered. This study conducted in 2023 shows this both human milk and donor human milk have significant protective effect in reducing the frequency of BPD occurrence compared with the preterm formula. And even when the amount of human milk is insufficient, feeding more than 50% of the human milk volume still provides the protective effect against the frequency of the BPD. Then next is role of vitamin A. Yes, there is a definitive role of vitamin A in BPD prevention. This systematic review showing the vitamin supplementation for short-term prevention of the short-term morbidity and mortality in VLBW infants, showing the marginal reduction in the composite outcome of BPD for death. But the new VITA trial shows the no significant reduction in the incidence of BPD via vitamin A supplementation. Next is there any role of nitric oxide? Yes, and nitric oxide, inhaled nitric oxide at the initial dose of 10 ppm seems more protective in reducing the risk of BPD than conventional treatment, and inhalational nitric oxide at the initial dose of 5 ppm in preterm infants at gestational age of less than 34 weeks who required respiratory support. However, the incidence of in hospital mortality and adverse events between the overall INO group and control are similar. Then we see the advances in treatment of BPD. Role of stem cell therapy. There is a potential. Stem cells have potential to repair, perhaps regenerate the damaged organ, and the mesenchymal stromal cells have ease of isolation, multi-lineage potential, and immunomodulatory properties. We can administer this by systemic or intratracheal administration, and the time of administration, route, and the dose, and the cell source and manufacturing process of the final stem cell product may influence the success or failure of the therapy. So we need more trials required for the role of this stem cell therapy. Then another study on melatonin efficacy. Yes, there is a role of BPD mortality and hospital stay reduction in case of BPD with melatonin treatment, but need more studies on this. These are the ongoing recent trials showing these drugs and the primary outcome of these trials. There are ongoing trials on surfactant, budesonide with surfactant, caffeine, hydrocortisone, ibuprofen, indomethacin, and vitamin A, nebulized furosemide, and inhaled nitric oxide. Then sildenafil, azithromycin, and another is cord blood mononuclear cells, and SMOF lipids. Then this table showing the new experimental drugs for the BPD, stem cell therapy, and their the mechanisms. First is stem cell therapy. It improved the cell growth and cell proliferation and angiogenesis, decreases the inflammation and fibrosis, decreases the oxidative injury. And other inflammatory agents such as DHA, pentoxifylline decreases the inflammation. Antioxidants such as superoxide dismutase decreases the inflammation and oxidative injury. And then nutrition supplements such as inositol and L-citrulline. Inositol increases the production of phosphatidylcholine and phosphatidylinositol, while the L-citrulline increases the production of nitric oxide. And then hormones such as erythropoietin, which causes upregulation of epidermal growth factor and decreases the alveolar simplification and decreases the fibrosis. And other growth factors and RNA have role in increasing the cellular proliferation, regulation of alveolarization and angiogenesis, and decreases the oxidative stress. These are the some drugs, but these are showing they have no role in the treatment of the BPD, like leukotriene receptor antagonist, inositol, N-acetylcysteine, lutein and xanthine supplementation, sildenafil, citrulline, and estradiol and progesterone. Take home message is lung ultrasound shows the good diagnostic accuracy in predicting the BPD at day 7 and day 14 of life. Use of biomarkers as a non-invasive strategy for early detection of the BPD. Then vitamin A, breast milk, and inhaled nitric oxide are effective in preventing the BPD. And various growth factors like insulin-like growth factor VEGF and non-coding and microRNA are under the clinical trial for prevention of the BPD. And mesenchymal stem cells has a role in prevention as well as treatment in of the BPD, but we need more trials on this. Thank you.